Hello everyone, my name is Waku Hatta. I belong in Division of Gastroenterology, Tokyo University Graduate School of Medicine. It is my great pleasure to introduce our article, Different Risk Factors Between Early and Late Cancer Recurrences in Patients with Additional Radical Surgery After Non-Curative Endoscopic Submucosal Dissection for Early Gastric Cancer, which is recently published in GIE. Endoscopic submucosal dissection (ESD) is performed widely as an established treatment for early gastric cancer with a negligible risk of lymph node metastasis. When a lesion does not fulfill the curative criteria for endoscopic resection of early gastric cancer, it is termed non-curative resection, and additional radical gastrectomy with lymph node dissection is the standard treatment for all patients because of the risk of lymph node metastasis. In addition, according to the latest Japanese guidelines, non-curative resection is mainly categorized as curability C2. Thus, in this study, we call curability C2 when the lesion does not meet the curative criteria for ESD of early gastric cancer. Our prior study reveals that cancer recurrence is observed in some patients with additional radical surgery after ESD categorized as curability C2, and lymphatic invasion was the sole risk factor for cancer recurrence in such patients. However, time to cancer recurrence is different in these patients. Thus, we aim to identify the risk factors of early and late cancer recurrences in these patients. This multi-center study analyzed 905 patients who were followed up without additional radical surgery after ESD for early gastric cancer, categorized as curability C2. The enrolled patients underwent scheduled surveillance using esophagogastrography and CT scan with a follow-up intervals of 0.5 to 1 years. In this study, cancer relapse in the lymph node and other organs after ESD for early gastric cancer was defined as cancer recurrence. As the first outcome measures, we investigated the rate and timing of cancer recurrence after ESD for early gastric cancer categorized as curability C2. Next, we evaluated the risk factors for early and late cancer recurrences separately with a cutoff value of 2 years between early and late cancer recurrence after ESD. The evaluative factors were tumor size of over 30 mm, deep submucosal invasion, undifferentiated type, lymphatic invasion, vascular invasion, ulceration score, positive vertical margin, and so on. Cox proportion hazard regression analysis was used to investigate the risk factors for early and late cancer recurrences separately after ESD for early gastric cancer categorized as curability C2. In the result, 5-year cancer recurrence rate in the enrolled patients was 3.2%, and time to cancer recurrence showed a bimodal pattern. The initial peak was 0 to 2.5 years, and the second peak was 4 to 6 years after ESD. Multivariate Cox analysis revealed that lymphatic invasion was a sole independent risk factor for early cancer recurrence, while other factors including vascular invasion were not risk factors. Regarding late cancer recurrence, vascular invasion was found to have nominal significance as a risk factor for late cancer recurrence, and lymphatic invasion tended to be associated with late cancer recurrence, but the association was not statistically significant. In the present study, we first found two clinical findings about ESD for early gastric cancer categorized as curability C2. First, time to cancer recurrence in patients who are followed up without additional radical surgery after ESD for early gastric cancer categorized as curability C2 showed a bimodal pattern. Second, and more important, the risk factors for early and late cancer recurrences in such patients differed: lymphatic invasion for early cancer recurrence and vascular invasion for late cancer recurrence, although correction for multiple testing of outcome data removed the latter's nominal significance. Moreover, although the association was not statistically significant, lymphatic invasion tended to be related to late cancer recurrence in such patients, and furthermore, we cannot ignore the high hazard ratio of 3.63 in this factor. Based on the present result, We can make two recommendations in patients who are followed up without additional surgery after ESC4R gastric cancer categorized as curability C2. One is that more attention should be paid to cancer recurrence regardless of whether the recurrence is early or late in patients with lymphatic invasion. In contrast, we should pay attention to late cancer recurrence in those with vascular invasion. Since no study has investigated the risk factor for early and late cancer recurrences after endoscopic resection for early gastric cancer, we believe that these results are noteworthy. These findings may help clinicians decide the treatment strategy for patients who have a relatively shorter life expectancy after ESD for early gastric cancer categorized as curability C2. Thank you. ありがとうございました。